Good morning, everyone. So let's start the Mr. Professor session of the management of IPMN. So I and Professor Bashi will talk about these topics, and I will talk about the IAP guideline, and Professor Bashi talk about the European guideline, and later we discuss about the difference. So at first, I will talk about the IAP guideline. There is no COI. So nobody know me, maybe that. The IAP guideline has been organized by Professor Masao Tanaka. And Professor Tanaka is my colleague, and I used to work with him. And now I stayed in the Kyushu University, Fukuoka, Japan. The first IAP guideline was published 12 years ago and have been revised twice. And the most recent version is the 2017 Tendai guideline. There are 3 points of the revision in the recent guideline: malignancy predictor, known as high-risk stigmata and worrisome features, and surveillance of benign branch duct IPMN, and surveillance after resection of IPMN. First, malignancy predictors. The red colored characters is the revised version, so you can find that a very minor revision. In high-risk stigmata, the size of enhancing mural nodule is determined as 5 mm or larger, and the nodule less than 5 mm is therefore included in worrisome features. Increased serum level of CA99 and cystic growth rate of 5 mm or more by 2 years are newly included in the worrisome features. But you should know that the high-risk stigmata and worrisome features consist of the clinical finding and the CT MRI findings. And the finding of US and the result of cytology is the further investigation. This is a comparison between the European evidence-based guideline 2018 and the recent IAP guideline. And everybody now knows that those guidelines is quite similar in terms of surgical indications. Next topic is surveillance of benign branch duct IPMN. The surveillance protocol is determined based on the cyst size. But this stratification based on the cyst size may disappear in the future because the basically progression of IPMN is quite slow. On the other hand, concomitant PDAC often suddenly happens and shows rapid progression. In the future, we should take these topics into account. This is our personal experience. This patient underwent every 6 months surveillance using alternate CT and US MRI. 6 months before, we cannot find any sign of concomitant PDAC in the pancreas head. However, 6 months later, we found that the locally advanced PDAC in the pancreas head involving superior mesenteric artery. This is the first case report of non-invasive concomitant PDAC diagnosed by ERCP pancreatic juice cytology. Thereafter, we reported many cases of early-stage pancreatic cancer diagnosed by ERCP pancreatic juice cytology. However, routine ERCP is not recommended in guideline because of the possible occurrence of the severe pancreatitis. Therefore, we should select the real high-risk patient who have indication for the ERCP pancreatic juice cytology. Now, Japan Pancreas Society conduct the prospective surveillance project of the branch duct IPMN using over 2,000 patients from over 70 institutions from Japan. And we use the protocol of alternate CT and EUS MRI every 6 months. This surveillance will finish in 2020, the Tokyo Olympic year. And then we put these data in the next revision of the IAP guideline. The last topic is surveillance after resection of IPMN. 4 possible events may happen after resection of IPMN: metastatic recurrence from the invasive IPMN, local recurrence including the residual tumor growth or monoclonal skip, and metaclonus new IPMN in the ruminant pancreas, and concomitant PDAC. This is our experience, and we focused on the ruminant pancreas after partial resection of partial pancreatectomy for IPMN. And we found that malignant lesion, the cumulative 5-year and 10 years cumulative incidence of malignant lesion are 7.8 and 11.8% respectively. And half of them are malignant IPMN, and the other half was concomitant PDAC. We analyzed the risk factor at the time of initial operation for the development malignant IPMN in the ruminant pancreas, and we found that malignant main duct IPMN located in the distal pancreas are the risk factor for the second malignant IPMN in the ruminant pancreas. Usually, the first and second lesion are quite similar, and we show that those 2 lesions are same based on the molecular assessment. And this may be explained by the mechanism of monoclonal skip progression via the intraductal dissemination. So there exists the clinical question for the prophylactic total pancreatectomy for all the cases of main duct IPMN. And this is our data. And the left slide shows that the survival after resection or partial resection of main duct IPMN is not different between the negative surgical margin and positive for low-grade dysplasia. In the right slide, so sometimes the second lesion develop in the ruminant pancreas, but ruminant total pancreatectomy provide the favorable prognosis. So additional resection is not necessary in negative margin or positive for low-grade dysplasia, and prophylactic total pancreatectomy is not necessary always. regarding the concomitant PDAC in the ruminant pancreas, we found that the IPMN with MAC2 negative pancreatic variability type and the resection of concomitant PDAC at the time of initial resection are the risk factor for the second PDAC in the ruminant pancreas. So we should know that the concomitant PDAC may develop multicentrically, so that long-term surveillance is necessary in the patient who survived after resection of concomitant PDAC. So this is the last slide, the future perspective. There are several nomograms in the world, but the diagnostic ability to detect malignant IPMN is not perfect. So the other method, for example, the molecular assessment of the EUS FNA sample or using the confocal microscope is necessary to increase the diagnostic ability to detect malignant IPMN. And even though the benign IPMN, preventive surgery is sometimes considered, especially in young patients who have the cumulative risk for the development of cancer, or high-risk patients who had family history of PDAC. In these cases, the minimally invasive surgery may be considered. And the most important thing, I think, that the early diagnosis is concomitant PDAC. So that's all. Thank you very much for the attention.